All right, welcome to Chapter 13, the respiratory system. Okay, so the first part of this chapter, we're going to talk about just some of the structural things within the respiratory system, and then we'll get into some physiology and kind of some specifics of how the respiratory system works. But we need to have a little bit of a familiarity of the structurally what's going on in there and what some of the things are that we're talking about. So some terminology in here that we're going to use, of course, nose, that's a tough one. But no, pharynx, larynx, trachea, bronchi, alveoli, those types of things are some terminology that we're going to use. I would recommend with some of this terminology, the terminology of the respiratory system is something that is referred to and used quite a bit in when we talk about disease processes and those kinds of things in specific teaching such as nursing or paramedic school. So I would try your best to make yourself as familiar as you can with them, with those types of terms, those structural terms, and even some of the physiology terms that we'll talk about here in a little bit. So you might make you some flashcards on these. It might be helpful to help you remember it. So those structures that I mentioned, of course, we've got the nasal cavity up there at the top. Nostrils, or nares, as they're oftentimes called in some anatomy books. We have an oral cavity and a pharynx. We also have a larynx. Down there we can see the trachea where it's got the rigid rings there between the lungs, and then we have the right and left main bronchus and the right and left lungs and the diaphragm there and there at the bottom. Remember, we're talking about right and left. We're talking about the patient's right and left, not your right and left. So that is helpful to keep you from getting confused. Okay, so some of the functions of the respiratory system, the main function is it's going to exchange gases between the blood and the external environment that we're in. And that's going to occur at the alveolar level. It's kind of a capillary level, or there actually is capillaries over the alveoli, so they kind of go a little bit hand in hand, alveoli and capillaries of the lungs. And of course, there's some passageways to the lungs that help to purify, humidify, warm the air, and kind of make the air a little bit safer and a little bit easier for our body to utilize those gases that finally get there. I want you to start thinking of the respiratory system and the way that our bodies interact with our environment in relation to the air that we breathe in and out, as those gases that are contained within that air we're breathing in and out. So that's really the concept that I want to get across to you, and it's probably the most important thing that we're going to learn in this lesson, is that gas exchange process. We'll spend a bit of time on that and talk about it so you guys can have a little better understanding of how it works and what's going on and kind of the purpose of it. Remember, all this is going to relate to the earlier chapter when we talked about the production of ATP and that Krebs cycle that needs oxygen and glucose in order to create ATP within the cells. This is where this oxygen is coming from, and we're talking quadrillions of molecules of oxygen, and that's a whole lot of zeros. That many molecules of oxygen that are being taken into our bloodstream. Now, there's more than that available, which we'll talk about the percentage of oxygen that's in our room air here in a little bit. So, all right, so what's the nose do? The nose has some olfactory receptors that's located in the mucosa, or the mucus area, on the top surface, or the superior surface. So at the roof of the nose, and not really the nose, but the nasal cavity inside of your nose, there's some receptors located there, very similar to the receptors that are on your tongue, where these sense, it's our sense of smell, where it picks up the chemicals that are in the air and relays that message to the brain, and the brain interprets that as, smelling pizza being cooked or something like that, because that's what it's sensing, and it goes off of memory. The rest of the cavity has some mucosa in there too. The rest of it's lined with mucosa. It's designed to moisten the air and trap incoming foreign particles. We primarily breathe through our nose most of the time. And this is especially true with newborns and infants. They are primary nose breathers. It is the primary way that we breathe typically, unless it's allergy season, and then we're all mouth breathers. But basically, for the most part, we breathe through our nose for those reasons, because it is part of our body defense system. In the nasal cavity, there's some projections in there called conchae. They increase the surface area and help create some turbulence within the nasal cavity to help kind of swirl the air around as it goes into the nasal cavity, stirs it up a little bit so the olfactory nerve can actually sense what's in the air. Also, so that some of them bad things can get trapped in the mucosa inside of our nose. Oftentimes we think about the sinusy drainage and all that stuff that makes boogers and as a bad thing, but really it's a good thing. And when our sinuses kind of kick into overdrive and they're draining and running, and we got all this snot running everywhere, it's actually a defense mechanism. The body's trying to defend itself from something it's perceiving as a threat, so it's trying to trap it in that mucus so that it can't get into our lungs. It's kind of a good thing, but it does have a tendency to go overboard when it's related to allergies like ragweed and crazy stuff like that. That makes it's like turning on a water faucet. All right, so the nasal cavity is separated from the oral cavity by a palate. That roof of your mouth, the hard roof of your mouth, there's two parts to that palate. One is the hard palate. Actually, there's bone there that makes it hard. And the back part of that, towards the back end, is a soft palate that does not have bone and it's not supported. So it's just tissue back there at the back part. All right, so there are some cavities within the surrounding bones of the nasal cavity called sinuses. And they're located in these areas. We call them the frontal, the sphenoid, the ethmoid, and maxillary sinuses. What those sinuses do, they actually create holes and openings and those kinds of things that reduce the weight of the skull as part of what it does, and we can see them pictured here. We can also see the folds inside the nasal cavity as well, but can see those sinuses in that particular picture. Well, what they're the paranasal sinuses, basically they help to lighten the skull because less bone, if it's an open space, it doesn't weigh as much as bone would. So also act as a resonating chamber for our speech. That's why when we plug our ears or we record ourselves speaking and we play it back and we think, oh my God, I sound like an idiot. Or that's not me. I don't really sound like that. Well, the thing is you're hearing your voice from the inside of your skull in those resonating chambers. You can't tell what they're doing to the speech that's coming out. So it sounds different to you than it does everybody else. So when you record yourself and you play it back, and you think, oh my gosh, I sound horrible, that's not what I sound like, and you don't want to listen to yourself recorded anymore, well, I have news for you. That's what the rest of us hear all the time when you talk. So more than likely, the way you think you sound and the way you actually sound, if we heard you the way you heard yourself, we would probably think that was weird. And we're pretty used to the way that you speak and the way that we hear you. So if it was different, if we heard it differently, it would be weird to us. So it's perfectly normal the way that you sound when you record yourself. That's how we hear you. So don't sweat it. All right? Then we have the pharynx or the throat. It's that muscular passage from the nasal cavity to the larynx. There's three regions of the pharynx. There's an oropharynx, a nasopharynx, and a laryngopharynx. The nasopharynx is high in the back by the nasal cavity. Oropharynx is kind of in the middle, right behind the mouth or right behind the tongue. The laryngopharynx is just below that area, just below the tongue, and it's where the larynx is located as well. The oropharynx and laryngopharynx are common passageways for air and food. The nasopharynx is not. So when you take a big old drink and somebody tells a joke and you shoot milk out of your nose, that's not normal, but it is possible. So it's not a normal route for food to pass. The other thing is Nasopharynx and oropharynx are pretty common terminologies that we use for some devices that we use. We use an oropharyngeal airway or a nasal pharyngeal airway. It's a type of airway device that we use when somebody's unconscious to hold their airway open. And it's a basic device that all of you guys will learn about if you have not already learned about it when you take a healthcare provider CPR class or a BLS CPR class, basic life support CPR class. So here's those broken down: the nasopharynx, the oropharynx, and the laryngopharynx. And they're kind of color-coded them so you kind of get an idea of which one's which. But that's where those are and what those are. Don't kill yourself with those. Just realize naso, oral, laryngo, where they're at. So it's just a geographical area that helps us relate things and talk about things at later times. There are some pharyngotympanic tubes that open into the nasopharynx. And of course, there's some tonsils of the pharynx as well. We call them the adenoids. There's some palatine tonsils and lingual tonsils. Remember, those tonsils are all part of our body's defense system. We talked about it in the last chapter, what these are for. When we talked about the endocrine system, they're all part of that endocrine system. Then we got the voice box or the larynx. I don't know why I always think of Sphinx when I think of larynx, like Egypt. I have no idea why, but I do, but that somehow makes me remember that that's the voice box. Not that I've ever heard a Sphinx speak or anybody has accused one of them lion-looking things with a person's head that talks or something. I don't know. Maybe in somebody's dreams or nightmares or in a really good Hollywood movie, but anyway, that's what I kind of relate the two to, and it helps me remember larynx is the voice box. It also it routes air and food to the proper channels, routes the food down the food pipe and the air down the windpipe, plays a major role in speech, and it's made of 8 rigid haline cartridges. It's cartilages in a spoon-shaped flap of elastic cartilage called the epiglottis. That's our food flap. Keeps us from having food and liquids go down into our windpipe. Typically, if it's working correctly, it closes up and keeps things from going the wrong direction, solids and liquids from going the wrong direction. However, if we're eating and talking or laughing or something like that at the same time, there's a pretty good chance that we can get something that would go down into the windpipe that doesn't belong, depending on what that is, especially if it's a liquid and what kind of liquid that it is. It could lead to infection and different types of things such as that can cause some problems in there as well. Then we got a thyroid cartilage. It's the largest of the cartilages. We commonly or most affectionately know it as the Adam's apple, much more prominent in men. That has to do with the development phases of having amounts of testosterone and things such as that make it a little bit more prominent in men, but it's still there in women as well. And of course, that floppy little epiglottis that protects the opening of the larynx routes food to the esophagus. However, when it's swollen, in cases such as epiglottitis, it can swell that epiglottis completely closed to where the air does not get in at all. And the person, the infant or the child with epiglottitis would die of suffocation if not treated or taken care of quickly. So it's one of the conditions that as healthcare providers we need to be aware of and know the signs and symptoms of, which we're not going to talk about in here, but know the signs and symptoms of so that if we have someone with epiglottitis, we don't run the risk of making it worse, because some of the things that we do as healthcare providers can actually make epiglottitis worse and make it swell up and completely occlude the airway. So we have to be cautious of those types of things, some of those things, and that's why we discuss these and we talk about them. Okay? Then we have the vocal folds, which are the true vocal cords. They vibrate with expelled air, and we control them with muscles to kind of make the sounds that we want to make. The glottis consists of the vocal cords and this split-like pathway opening, so it's kind of kind of a wedged opening, and I didn't see a really good picture of it in your book, and I didn't think to throw a picture here in these slides, but it's kind of a wedged-like opening, and those things, the vocal cords will move back and forth, and they're actually kind of a white in color, unless they're a smoker, then they're kind of yellow, but the edges of them are kind of white, and what it does is it directs or funnels, changes the shape and the way that the air passes over them, gives us voices and sounds, and then we use our tongue to kind of manipulate those sounds and that kind of thing. That's why it takes a very long time for a child to learn how to talk, regardless of the language. Now, I can't imagine how it would be to learn how to talk when it's one of them little clicking languages, like, I have no idea how they learn how to do that, but it's all different for, all of us, but it basically requires the same thing. It's air moving over the vocal cords, and us knowing how to manipulate that air to make the sounds that we want to make. And then we're actually talking about this area down here. Here's the epiglottis right here, and we don't really see. Oh, here it is, right here. Here's the vocal fold right here, but we can't really see it. It's not really a good picture. Like I said, it's just not. I'm sorry, that's not the epiglottis. This is right here. Duh. Don't pay any attention to that. It's that right there. But you can't really see the vocal folds in here very well, or kind of get a really good idea of what they look like. And like I said, there's just not a really good picture that I've seen that they give us. So we're kind of stuck with what they got. All right, the trachea, also known as the windpipe. I often call it the windpipe, but it is the trachea, or the air pipe, or that kind of thing. It's that 4-inch long tube that connects the larynx with the bronchi, or the branching part of the lungs. So the walls are reinforced with C-shaped cartilage, which keeps the trachea solid, patent, and open, so it keeps it like a tube, like a garden hose that you can't really, well, you can kind of crush it, but we won't get into that. Usually it's some sort of trauma that does that, and it's not a good thing. This windpipe is also lined with cilia, which we've talked about in previous chapters, that beat continuously in the opposite direction of the incoming air to kind of push mucus that's loaded with dust and other debris away from the lungs, and eventually we'll give a little cough that stuff up, and as disgusting as it sounds, most of the time we swallow it, which in the stomach is a very hostile environment for any of that stuff, so the hydrochloric acid that's present in the stomach does pretty quick work of anything that's trapped in that mucus, but the mucus does a very valuable thing. It keeps that stuff from, setting up shop in the lungs and creating infection. However, if we have too much mucus, it's going to affect our ability to exchange air in the lungs, in the alveoli of the lungs, which we'll talk about a little bit more here in a bit. Okay? So there's kind of an idea. This up here at the top is the esophagus. So, you kind of look at it and go, what in the heck is that weird looking thing? But this up here at the top, this right here is the esophagus, right here. And here's the cartilage rings of those. And you can see there's some muscle back here as well. And then this is just an opening. We can see the little cilia in here, and this is all just open for air to travel through. So that's just a cross section of that. There's another picture of those cilia. The thing is those are very easily damaged by environmental factors such as cigarette smoking or exposure to chemicals and those kinds of things. They're fairly resilient in the fact that they will grow back in most cases. Some cases they won't. But this causes big problems with smokers is they damage the cilia from all the smoke and smoking and all that kind of stuff, and they don't bring those mucus plugs up as effectively as they should. And then that's why the smoker, when they wake up a lot of times in the morning, they've got kind of this hacking cough because now that stuff's kind of worked its way up while they were sleeping and can be coughed out. All right, so then we have the primary bronchi. We have a right and left, and it's formed by the division of the trachea. That little division, that little spot right in the middle where those two divide is called the carina. It is sometimes mentioned in other disease processes and that kind of thing as a point of reference. So there's a little bitty, it looks like a little pair of whitey-tidy underwear right there. And if we have another picture, I'll point it out to you. But there's a carina there And that's where the division of the right and left bronchi are. Okay? The right bronchi is wider, shorter, and a little bit straighter than the left. That's important because when we do a procedure called endotracheal intubation, where we take a tube and we put it down somebody's throat into their trachea, if we push that tube in too far, it will go straight down into the bronchi of the right lung. All right, why is that bad? Well, when we start squeezing the little breathing bag or the ambu bag, we only push air into the right lung and not the left lung. So that could be problematic. And because we're not getting enough air, we're not ventilating well. So that may be kind of a problem. All right, so here's oh, there it is, right there. Anybody see the little pair of whitey tighties? Right here, it's right here. That little deal right there is the carina, and I don't know why it looks just like a little pair of whitey tighties or something. Maybe we could write Fruit of the Loom on that or something, and it would. It would look like a little whitey tighty. Sorry, that's just me though. All right, so the lungs occupy most of the space in the thoracic cavity. The heart's kind of in the middle. We talked about that earlier. The apex of each lung is near the clavicle, so that's the top. So remember, the apex of the heart was at the bottom. With the lungs, the apex is at the top. So the bases are down on the diaphragm, and each lung is divided into lobes by fissures that are on them. The left lung has 2 lobes, the right lung has 3 lobes. I asked a doctor one time, I said, Doc, how's come the left lung has 2 lobes and the right lung has 3 lobes? Without missing a beat and with a completely straight face, he looked at me and said, that's the way God made us. Who could argue? I have no idea why there's, other than that's the way God made us, probably the best answer that I've received to date. Some might say that because of the heart kind of lays a little bit to the left, kind of crowds that left lung a little bit. Maybe there's not space for 3 lobes. I don't know. But obviously, that's the way we're made. So that's kind of the way it is. There are some coverings on the lungs that protect them. The thing is the lungs need to be able to move freely within the chest cavity. So they need to not be rubbing up against other things. So we have this serosa, that covers the outer surface of the lungs, and we call that the pleura. So we have the pulmonary pleural coverings on the surface of the lung, and then we have the parietal pleura that lines the walls of the thoracic cavity. Just like when we talked about in previous chapters, the linings or the coverings over particular organs that make those organs, that separate them from all the other organs in the environment and allow for some movement. The heart was another one of those that kind of needs to move without being friction. The lungs are very much the same way. So we have this pleura. We have a parietal pleura and a visceral pleura. The visceral covers the lung. Remember, that hadn't changed. The parietal pleura lines the walls. The thing to remember with this is there is a potential for a space in between there. And there's usually fluid in there. There should be fluid in there. This really slippery fluid is in between those 2 linings, those 2 membranes, and that's what gives the slippery nature of it. It is possible to get an infection in that space between those 2, in that slippery space, and all of a sudden have some friction. It's very painful. It's called pleurisy. And if you've ever known anybody that's had it or had it yourself, it is very painful. It's very difficult. Makes you not want to breathe because it hurts to take a breath every time. But it is very treatable. Usually antibiotics will clear it up. It's pretty common in smokers, sometimes asthmatics, or people with depleted immune systems. All right, so remember, there's a potential space in there. That potential space is also important when we have lung injuries, such as a penetrating injury to the chest, gunshot wound, stab, something like that. That space can actually fill up with blood or air as well. If it fills up with blood, we call it a hemothorax, because hemo means blood. If it fills up with air, we call it a pneumothorax, and you think of it like pneumonia. Pneumonia is the lungs, air, pneumo. Pneumothorax is air in that pleural space, that pleura, that space around the lungs, or we can kind of see it right here. Right here it will be filled with fluid, but blood and air can get trapped in there if we have an injury to the chest wall. or an injury to the lung internally, blood or air can get trapped in there. And this is where they'll go in there and they'll put a chest tube in to drain all that stuff. If you're a paramedic, you can. We've got some needles that we can use, and we can do needle decompressions to either let air or blood out of that space to improve the breathing ability. This blood and air can get trapped in such volumes that it completely impedes the lung's ability to exchange those gases or exchange air with its environment, and put so much pressure on the heart that everything just stops. So it is a very serious issue and can be very life-threatening. So it has to be treated. Usually has to be treated right away. Once again, we can see that space here, but you can also, I like this picture because we can see some of the vascularity of the lungs as well. We need to realize that the lungs are very vascular. They have a lot of blood vessels, lots and lots of blood vessels in there. So also we have this potential space around here that can get blood and whatnot trapped, just like we did with the heart. We had the same thing in the heart. So esophagus is right here. Here we can see the top of the heart, pulmonary arteries, pulmonary veins going back in, and then all these vessels. That's a pretty good depiction, and that's why, they call the bronchial tree, but the vessels inside of there look like a tree as well. So very vascular, lots of blood vessels. So lots of potential for bleeding when there's injuries to that particular area. Okay? All right, so now we have the bronchial tree and the divisions of that. So we have the main stem bronchi, the right and left, the primary, remember? And then we have secondary bronchi, tertiary bronchi, bronchioles, and terminal bronchioles. These bronchioles and terminal bronchioles that we see down here at the bottom, these last two on the list, are the two that we can usually affect with using some sort of medication to help somebody breathe. That's the two that we might actually be able to make somewhat of a difference with. These others up here don't have enough muscle in them for us for the medication to be helpful. I went out and found this great picture of a bronchial tree, and we can see kind of how that looks. And I'm a little disappointed with this one here, because my Fruit of the Looms don't look much like Fruit of the Looms in this one, but that's the carina, and it's spelt like that, carina. It's one of the few words I know how to spell well, even though it has 3 vowels. It's weird, I know how to spell that one. But here's the bronchial tree, so you can see all the cartilage of these. This cartilage helps keep these open, so it gets all the way down here, and then you'll notice the cartilage kind of is gone. And, it's not showing any more of the tree down here. Well, this is just showing the bronchial tree that has haline or rigid cartilage in it, okay? So that's what it's showing. It's showing that. But be aware, there is other parts of this bronchial tree that doesn't have all that cartilage, and it has much more muscle. So we can see this come all the way down here, and what that last picture that I just showed you, that all this cartilage, here's the carina again. Yay, it looks like kind of like Speedos now, but here's the carina, all the little haline cartilage coming down, and there's getting less and less and less and less haline cartilage as we get down here. And then we get down to the bronchioles, no haline cartilage, and this is surrounded with bands of muscle. And you might ask, why is there muscle in the bronchioles? Well, that's a protective mechanism in part, where that it can kind of constrict and restrict airflow or the flow of something else that doesn't belong. Problem is, we can get irritants and things like that down in there if you're an asthmatic or somebody with some other respiratory related disease such as emphysema or something like that. Of course, emphysema actually is more of a problem down here. We can do a little work here to help them, but not much. But with asthma, it causes those muscles to constrict right down here, and it collapses or closes off these airways down here at the bottom. And what we can do is we can give something like, Atrovent, or what's the other A one? My mind's went blank. One of the old ones they used to give is atropine. They don't do it so much anymore. It's albuterol. This albuterol is also the most common one that we see in the little inhalers, the little puffers. And what that albuterol does, atropine, albuterol, these are all in that category of, and please don't send me nasty emails because I'm writing something new in here that's not in your book. But these actually affect, beta 2 receptors. We didn't talk about this, but beta 2 receptors, there's beta 1 and beta 2. Beta 1 is in the heart, beta 2 is in the lungs generally. If we give a medication that affects beta 2 receptors, it's mainly going to affect the lungs. If it's a beta 1 receptor, it's going to affect the heart. The interesting thing about atropine is it is a beta 1 and 2. So no matter where we give it, especially if we give it in an IV, it's going to affect the heart. If we give it in a breathing treatment, like most of these are given, then it's going to affect the lungs and probably the heart a little bit too. So it may increase the blood pressure and make the heart beat faster and those kinds of things. What it is we're trying to do that fight or flight response is what we're looking for, but we only want it to affect the lungs, so we only want a beta 2 effect. So we're going to give a breathing treatment, and a mist of this medication is going to get all the way down here to these little bronchioles, and it's going to cause those bronchioles to dilate. It's going to relax those muscles and cause them to dilate. And that's us forcing a fight or flight response. But we don't really need the fast heartbeat and all that stuff. We just need the beta 2 of the fight or flight response. And what happens during fight or flight is the heart starts beating faster, the blood pressure goes up, the bronchioles and everything dilate in the lungs so we can get more air in. The body's ready to bring in more oxygen, pump more blood, and ready to fight or run or whatever it's got to do. Well, what we do with somebody that's having an asthma attack, we stimulate those beta 2 receptors in the lungs so they'll dilate, but we don't really want to stimulate the ones in the heart. That's why atropine, which used to be widely used, is not used as much. Atrovent is very similar to atropine, but it's different in enough properties that it doesn't affect beta 1 as much. And albuterol's been around for years, and they all will affect the heart a little bit, but not a lot. The amount that they affect it is not that much, except for atropine. Atropine may have a significant effect. So just kind of a breakdown, an idea of what that bronchial tree and where those muscles are located down there on the very distal ends. So when we give respiratory medications, that's what we're primarily affecting. Now, that being said, there's steroids, there's other things like that we can give. Some of them are inhaled, most of them are IV, some of them are pill form. That can affect the lungs, but realize that the steroids primarily are for inflammation. They're to help inflammation, the swelling, part of that inflammatory response, and we're trying to target the lungs, but most of the time we have to target the whole body with steroids, not just the lungs, so kind of the way it works. All right. So, specific respiratory zone structures, we talked about the bronchioles. Then we have alveolar ducts, alveolar sacs, and alveolar air spaces. Now, this little picture down here, it kind of gives us, it tells us where the alveolar sacs are down here at the very bottom, where I've circled it. That's the alveolar sacs. It looks like grapes. So, and here's a little better picture of it, and it shows us the ducts and all that stuff. There's the bronchioles down here, the duct down here, and the alveoli here. And you may be curious what these little alveoli are. Well, that is the actual place where the gas exchange occurs. These are little sacs. You see the air comes in from right here. The air comes in, and then we have all of these little pores and all that stuff on these sacs. But this is these alveoli, and you can see these little striations here on top of these sacs that kind of control the size of them or helps to keep them in the right shape and size. Air comes in, and these alveoli are very, very thin membranes. Over the top of these membranes, it's covered in blood vessels. And they don't have them in this, but we got all kinds of little capillary blood vessels covering all of those alveoli in there. So when that air comes in, gas, that oxygen that we breathe in can pass from the air in our lungs into the blood vessels and onto the red blood cells. And also we'll have some CO2, carbon dioxide, coming off of those, coming out of the bloodstream into this space inside of those alveoli so that they can be breathed back out. And all that stuff happens in a breath of an air, in an air breath, in one respiratory breathing cycle. So all of that happens then. Okay? It's a little more complicated than that. We're going to talk about it a little bit more, but without getting way too far ahead. So that respiratory membrane, and what we're talking about with the respiratory membrane is the alveoli, or alveolar walls. It is very thin, squamous epithelial layers that line those walls. These little pores connect with neighboring air sacs. There's a bunch of capillaries, arteries and veins, those little bitty, fine, small capillaries that are over the surface of those alveoli. And this membrane you should think of it as the air-blood barrier. The barrier between the outside air and the blood in our bodies. And it's very, very important that that barrier is not too thick. It needs to be just the right thickness so that those gases can pass across that membrane and in and out, either out with the bad gas, in with the good gas kind of thing. So gases are going to cross that membrane by diffusion. Simple diffusion, regular diffusion, nothing complicated. Oxygen will enter the blood, carbon dioxide is going to leave into the alveoli. There's some macrophages down there that are some added protection by taking care of some bacteria and those kinds of things, because remember, we're interacting with our external environment, and it needs to be protected. The respiratory membranes are very fragile. They're very brittle. So not really brittle, but they're fragile. They can be damaged easily. Different diseases, different exposures to harsh chemicals or inhaling different things can mess with the surfactant that's over those alveolar surfaces, so the alveoli starts to get sticky and rigid and that kind of thing and doesn't work well. Cigarette smoking causes the alveolar sacs to lose their elasticity, so they're not as elastic and they become more, instead of like a soft, soft balloon, so to speak, they become more like a plastic grocery sack. So they're not as flexible, they don't function as well, and those types of things is what smoking does to us at that level. But we can kind of see those little bacteria and whatnot floating around down in those areas, kind of looking for trouble, trying to keep things clean, and we can see the thickness of this membrane. We can see the thickness of this membrane right here. So that the gas exchange can occur across that membrane. Okay? All right, good video for you that talks about the oxygen movement from the alveoli to the capillaries. So you get an idea. I want you to watch this. I want you to get an idea of how oxygen gets from the inside of the alveoli of the lung as a gas form. Remember, these gases can actually penetrate into liquids, right? We've talked about that before. And that's what it's going to do here. It's going to go from a gas form through a liquid and attach itself to a red blood cell. So let's give it a watch.
So imagine you have a molecule of oxygen. It has to first get into your mouth, or I guess it could also go through your nose. And it's going to join up. Is the FiO2 what I thought it was? What happens, right? And it can split off to your left lung or your right lung. Let's say that we're facing this person. On the left, you've got one lung over here with a little cardiac notch for the heart. And on the right side, you've got...
Not be so loud for us.
One does not have...
Trying to get the volume down on it, but... Oh, wow. That's interesting. They won't let me do that. Hang on, let me... Oh, that volume's just kind of blasting, so... Let me back it down just a little bit. Sorry about that. And I'll back that up. Back this up here. Okay, this time for sure.
So imagine you have a molecule of oxygen. It has to first get into your mouth, or I guess it could also go through your nose. And it's going to join up either way and go down into your trachea, right? And from there it can split off to your left lung or your right lung. Let's say that we're facing this person. On the left you've got one big lung over here with a little cardiac notch for the heart. And on the right side you've got the second lung, of course, and this one does not have any spot for the heart because it sits on the other side. And what I wanted to do is actually kind of zoom in and focus on this little alveolus right here, because we know we have millions of these alveoli in the lungs, and that's where all the gas exchange is happening. But exactly what happens needs to be clarified. We need to kind of zoom in and get some details. So let's focus in on what happens here between the alveolus, which is the last part of that bronchial tree, and the blood vessel. I'm actually going to speed this up for you. So there you have all the layers between the alveolus and the capillary. Pretty impressive, huh? Now we have this molecule of oxygen drawing a circle around it. It's going to make its way from this alveolus out of the gas, and first it's going to have to go into the liquid phase. That's kind of a big deal, right? It's going to enter this thin layer of fluid which coats the inside of the alveolus. Then the molecule of oxygen is going to go through the epithelial cells. Those are the cells that kind of make the walls of the alveolus look the way it does. These are kind of the flat pancake-shaped cells. And it's going to go into the basement membrane. This basement membrane, remember, is kind of a foundation, offers a lot of structural support to the lungs. And below the basement membrane, it has this layer of connective tissue that this molecule of oxygen has to get through. Enters another layer of basement membrane, and then it goes down into the endothelial cells. These are the cells that also kind of pancake shaped, and these are going to make the walls of the capillary. From there, the oxygen molecule goes into the plasma and then finally gets into the red blood cell. And of course, the red blood cells are packed full of hemoglobin, right? So this is a little hemoglobin protein here. And this hemoglobin has 4 spots on it. It's going to allow 4 molecules of oxygen to bind it. And so once our oxygen gets there, it's going to hope to find some hemoglobin that it's got a little free spot. And once it binds to the hemoglobin, the red blood cell is going to now carry that oxygen out to the rest of the body, wherever it's needed. So that's kind of how oxygen gets from the alveolus out to the body. Now let me make a little bit of space. I'm going to show you what I want to do. I want to do kind of an interesting thing here. Hopefully it'll help you understand this journey that the oxygen molecule is taking a little bit better. So let's imagine something like this, where you've got a nice little rectangle. I'm going to try to draw this rectangle out on the side for you in kind of the same way I'm drawing it here. So just keep your eye on the colors, because I'm not going to relabel anything, just to kind of keep it nice and easy. What I'm going to do is just imagine that the oxygen is starting at the top of this rectangular, three-dimensional square-like object I'm drawing. I guess a three-dimensional cube, rectangular cube. And then it's got to get to the bottom of this rectangular cube. So at the bottom we've got the red blood cell and the hemoglobin, right? That's the last layer down here. And the top layer was the alveolus, or the gas. So let me actually sketch that in as well. And so that would be the very top layer. And it has to get through all these layers, right? This blue layer, for example, this is that liquid that's lining the inside of the alveolus. And let me draw a molecule of oxygen starting its journey up here. That's the gas phase, right? So it has to actually get from that gas stage through the liquid layer into the next layer, which is the epithelial cell. That's this guy right here. That's the second layer. Third layer we said was the basement membrane, just kind of going through them one by one. And this is also kind of a nice way to review, I suppose, as well. Then you have all that connective tissue, nice thick layer of connective tissue. That's the green. And remember, the basement membrane and the connective tissue, they're both chock full of proteins, different types of proteins, but both there for structural support. Got some more basement membrane here on this side, and this is going to be right before you get to the endothelial cells, right? That was the endothelial layer. This is the cell that kind of offers the capillary walls. And then we've got some plasma, we said. The oxygen has to get through some plasma, and finally is going to get into the red blood cell. So this whole bit, the reason I'm even drawing it like this, or taking all the time to draw it like this, is that this entire layer right here, this is all liquid, right? This is all liquid and predominantly water. So remember, our bodies are heavily water-based. So our molecule literally is going from gas, which is at the top of our rectangular cube, all the way down through many, many different layers of liquid. So it kind of makes it easy if you kind of divide into these two categories, gas and liquid. In fact, this is now hopefully going to help connect with these equations that we've been learning. So now let me throw up a couple of equations that we've talked about before, and let's see if we can figure out how they relate to what we're kind of going through now, and whether there's any clear relationship as to how to use these pictures that we've drawn up. So this first equation, this is the alveolar gas equation, right? We've talked about this before. There's a video on this as well if you want to refresh yourself. The first part of this alveolar gas equation tells us how much oxygen is going into the alveolus. Remember this top layer right here, this is our alveolus right here. So it says how much oxygen is going into that alveolus, and this is actually, this second bit is how much is going out. And if you, of course, subtract what's going in from what's going out, you're left with what is the partial pressure of oxygen in that gas space. What is this blue PO2 equal? And this is actually kind of a nice segue for our second equation, right? We have this second equation which helps us figure out how much oxygen is going to diffuse, or any molecule really, according to this formula. This is Fick's law, and we can actually figure it out by taking a few parameters. We can say, well, if you know that the gradient, P1 minus P2, is a certain amount, and if you know the area and the diffusion coefficient and the thickness, then you can figure out V. And this V is really the amount of oxygen in this case. We're going to focus on oxygen right now. Amount of oxygen diffusing over time. So this is actually very helpful, because if you start noticing that the amount of oxygen diffusing over time, or the oxygen delivery that's coming into the red blood cells, is low, then you might start wondering why that could be. And remember the red blood cell layer that's down here, this is our red blood cell layer. So you start wondering, how is oxygen getting from that alveolus down to the red blood cells? And we can call the partial pressure of oxygen in the alveolus, we can call that P1, and we can call the partial pressure of oxygen down here into the red blood cells, we call that P2. And so then when we figure out from the alveolar gas equation what this is, that is basically telling us this, right? So the two equations are basically very related. So if I notice that the amount of oxygen diffusing from the alveolus to the red blood cell layer is off, if it's less or more than what I expect, I have to go through a mental checklist. I have to think, well, is the FiO2 what I thought it was? Usually room air is 21%, but maybe this person is on 40% or 50% because they're getting a face mask and they're getting a lot more oxygen than what is in the environment. So that could be one reason for getting a higher value. You might also get a higher or lower value because maybe you're not at sea level. Maybe we're working with a patient at a mountain level, or maybe below sea level. So that could also explain an abnormal amount of oxygen diffusing over time. And these two things that I've drawn in an orange box, they're both going to affect P1, right? This is the initial partial pressure of oxygen in the alveolus. Some of these things are probably less likely to be changing, right? I wouldn't expect that the respiratory quotient is changing. If the person has kind of a steady diet, then that shouldn't be any different. The partial pressure of water probably also isn't changing, especially if we're at body temperature. And the partial pressure of carbon dioxide, that could actually change, but just to keep things simple, and if I'm only thinking about oxygenation, I'm just going to assume that that's going to be probably not the reason either. So going through my mental checklist, I know P1 is going to be something I want to think very carefully about. Also want to think really carefully about area. What if the person I'm dealing with has had many alveoli that are no longer working. Let's say only half of their alveoli are working. That means that half of their surface area is gone, right? So they're really not getting as effective gas exchange because half their surface area is gone, and effectively only half of their alveoli are able to get oxygen to diffuse across. So surface area is very, very important to think about. And as is thickness. And when I say thickness, remember, the oxygen has to get all the way from this gas layer down into the red blood cell layer, right? So that's a very big way to go. And if you add a bunch of liquid to this layer right here, maybe to the connective tissue, if there's more fluid in those particular layers, those are usually the ones affected, then that's going to increase the thickness. So there's one more reason for why my amount of oxygen diffusing over time may be off from what I had expected. And again, down here, I wouldn't expect my diffusion coefficient. I wouldn't expect this to be different than what I had expected, because the diffusion coefficient is pretty stable, right? If we know that we're talking about oxygen within water at a certain body temperature, that's not going to change a whole lot. And finally, this P2, this is the partial pressure of oxygen that was returning from the body. So if the body is using up a bunch of oxygen and returning it, what is the oxygen level in that blood that's coming back? And I wouldn't expect that to change much, because the body is probably using a fairly consistent amount of oxygen. So I'm not going to assume that that's the reason. So again, if you ever kind of come across an abnormal amount of oxygen diffusing over time from the alveolus down into the blood, you got to go through this kind of checklist and think about these formulas and how they help us be very systematically going through each of these variables and thinking, what could be the reason that the amount of oxygen diffusing over time is more or less than what we expect?
Hopefully the math in that didn't make you just get a little nauseated and give up on it, because there is some very good information in that I wanted you guys to see, especially as it relates to how the amount of oxygen that's present in the lung, as well as the thickness that oxygen has to travel to, will affect how much oxygen actually makes it to the red blood cell. The reason why I wanted to point that out to you is there's all kinds of things in our environment and even medical issues that can affect both of those things. For instance, you go to the top of Pikes Peak, the air is a little bit thinner, the oxygen level, the percentage of oxygen that's present is still 21%. There's still 21% of the air that you're breathing in contains oxygen. It just has less oxygen molecules in it. So it's going to have less oxygen pressure, and the partial pressure that it's going to exert is going to affect the diffusion across those membranes. So one of the things that we can do is we can add supplemental oxygen, increase the partial pressure of oxygen to force more across that membrane. The other thing that can happen to us too is we can have some sort of a disease process that either thickens the wall of the alveoli, or in the case of like pneumonia, gets a lot more fluid in that alveoli. Those gases still have to cross through either that thickened wall of the alveoli or all that fluid. So it affects that. Just because we have a certain percentage of oxygen present in the alveoli doesn't mean that 100% of that percentage actually makes it to the cell. Remember, it's got to travel all that distance, so only a small percentage of what's present is actually going to make it to the red blood cell. Therefore, if we have more obstruction or more things in the way between the alveoli and the red blood cell, less oxygen's actually going to get there. And there's several disease processes that can cause that for a variety of reasons. So it's important to understand how all of these things come into effect and affects how much oxygen actually makes it to the red blood cell. So if we have somebody that, say, has pneumonia, and we put them on the little pulse oximeter, you know, the little deal that they put on your finger that reads how much oxygen is in your body, if we put them on one of those and we notice they're breathing normal, but yet they're not getting enough oxygen in their blood according to the pulse ox reading that we're getting, then what we can do is we can put them on some supplemental oxygen, increase the quantity, the amount of oxygen in the lungs, and when we increase the amount percentage-wise of oxygen in the lungs, then we increase the pressure that oxygen exerts, forcing itself through all those membranes and tissues and fluids, okay? Normal air, 21% oxygen. When we put somebody on a nasal cannula, we might bump them up to 24, 25%, all the way up to what's called a non-rebreather mask, a mask with a little bag on the bottom of it that is 100% oxygen. So all of the pressure that they're breathing in, all of the oxygen or the air they're breathing in is 100% oxygen. And we won't really get into atmospheric pressures and all that kind of stuff because, well, basically where we're at right now at sea level, atmospheric pressure is 14.7 pounds per square inch. If we go way up in the air high, that pressure drops because there's less air up there. The air gets thinner. Still 21% oxygen, but just less air overall. Or if we go underwater, if we take air with us and we go underwater, the weight of the water actually increases the pressure of the air that we take with us exponentially. So for every atmosphere or every 30 feet that we go down underwater, we increase 1 atmosphere. So here at sea level, 14.7 psi or pounds per square inch. We go underwater 30 feet, it's like 29 point something, it doubles the pressure. So 21%, an oxygen mixture of 21%, 30 feet underwater is going to force more oxygen across those membranes. Why is that important? Why am I talking about that? Well, because in some instances, we might need to put somebody in what's called a hyperbaric chamber, or a chamber that simulates diving, that increases the pressure on our bodies, that simulates diving for whatever purpose, whatever they're treating for, whether it's, carbon dioxide poisoning or burns. We use it for the treatment of burns to get higher percentage of oxygen to the cells so that they can heal faster and those types of things. So that's why I felt it was important to talk about all of this, because I want you to have a greater understanding of it. Is this something that I'm going to test you on? No, not really. I'm not going to ask you questions about, especially the math questions. How mad would you guys be if I did that? So no, I'm not doing that, hitting you with the math or anything. This is just to increase your knowledge. Feel free to watch this video again. Think about it. Don't get panicky over the algebraic and chemistry kind of look of the math. We're not asking you to do the math. He's just pointing out how we come up with what we come up with and how it gets to the red blood cell and from point A to point B. Also realize that the reverse happens with CO2. Remember, the reason why that oxygen is going from the alveoli to the red blood cell is because there is no oxygen on the red blood cell, and there's oxygen in the alveoli, and the pressure that those oxygen molecules exert push it down through that tissue onto the red blood cell. Same thing happens in reverse with CO2, carbon dioxide, or carbon dioxide. CO2 on the red blood cells, there's CO2 there. There's no CO2 in the lungs, so it diffuses back across those tissues and goes out. So that's how all that works. I know it sounds very, very complicated. It's really not terribly complicated. It's just conceptually difficult sometimes to get. Once you get it, once you've spent a little bit of time getting it, believe me when I tell you, you're going to be leaps and bounds ahead in understanding various different disease processes and those kinds of things, because it'll click, it'll make sense. You'll go, oh yeah, that's because this is happening. It makes it a lot easier to be able to do that. So, onward and upward. There's 4 events that happen during respiration. There's one. The first one's called pulmonary ventilation, moving air in and out of the lungs. This is oftentimes called mechanical respiration as well. But pulmonary ventilation is the moving of air in and out of the lungs, or breathing, okay? What you need to realize is we can be breathing and it may not be working. So it's very possible to have a mismatch there, even though somebody is breathing. It just may not be working effectively. When that happens, it's a term that we call respiratory failure, meaning the respiratory system is failing to work properly, even though it's trying to work. It's just not working. Just a term, you're not going to be tested on it, but that's what we call it when there's a mismatch. External respiration is the gas exchange between the blood and the alveoli. Okay, that's event number 2. Of course, we know what goes on there after that video. Then there's the respiratory gas transport. It's the moving of oxygen, carbon dioxide through the bloodstream on the red blood cells, or bound in other forms. And then internal respiration, which is between the blood and the tissues in the capillaries. And then we could take it a little bit farther and we could say cellular respiration is that Krebs cycle, remember that? So that all is kind of how that happens in those phases. Each one of those phases are important. The three being probably the one that you'll probably never hear that called that respiratory gas transport. But you very likely will hear mechanical respirations or pulmonary ventilation, same thing. External respiration, you may hear that heard, and internal respiration and cellular respiration. Remember, cellular respiration is the movement and consumption of oxygen during the Krebs cycle or the citric acid cycle within the mitochondria of each one of the cells that produces ATP and gives off CO2, right? Remember that? I know you guys are going, oh man. So hopefully all this is starting to make a little bit more sense to you about how all this works and how the body works. Feel free, if you're struggling to understand it, to kind of draw it out. Kind of write it out on a piece of paper or make you a drawing of how you perceive that all of this works and it gets to creating ATP. It's conceptually, like I say, it's a tough concept sometimes to get just because it's like, wow, there's a lot to that and it's different. It's a lot of times different than the way we perceive things as young children that is kind of ingrained into us, so we have to learn something new, a new way to do it, so it's kind of tough. But hang in there, you'll get it, and keep trying, keep fiddling with it, keep studying, keep reading, looking for resources, reaching out on YouTube, finding those kinds of things that will all help you. So, breathing. It's a completely mechanical process that depends on the volume exchange in the thoracic cavity. So, when we breathe, it's all mechanical when we're talking about breathing. The volume changes lead to pressure changes, which lead to gases going in and out of the lungs. This is a very wordy way of saying, how do we breathe? Well, what happens is when we take a breath in, the diaphragm contracts and moves downward towards our belly button or towards our pelvis. It moves downward. The the muscles in between our ribs pull our ribs outward, away from our body. It pulls those ribs out. And what happens is it creates this space inside of our chest, and that space inside of there kind of creates negative pressure. So if you've ever taken an empty syringe and held your finger over the tip of it, obviously a syringe without a needle, but held your finger over the tip of the end of that and pulled the plunger back, and remember, you know how it creates a vacuum inside of there? We do the exact same thing inside of our bodies when we take a breath in. The only thing is obviously we have an opening, so air rushes in. When all of those muscles relax, the diaphragm goes back to its normal place, the ribs go back to their normal place. It creates pressure inside of inside of our chest cavity, and the air moves out of our lungs. So the process of moving air in and out of our lungs, the pulmonary ventilation, is all done off of positive, negative pressures created by muscle movement that opens up and opens or makes the cavity inside of our chest bigger or smaller. Okay? So hopefully that's not too tough to understand. Oh my gosh, what am I doing here? Making little marks everywhere. And anyway, so it happens in two phases: inspiration, exhalation, or inhalation, exhalation. Inhalation is air going in. Exhale is air leaving, going out. And this is just exactly what I told you. The diaphragm and intercostal muscles moving on inspiration, changing the size inside of the cavity and creating a negative air pressure inside. We can see that. This kind of depicts that a little bit. Not super easy to see, but it creates a larger space inside of the thoracic cavity. Expiration is the opposite of that. Everything relaxes. Elasticity kind of brings everything back in, pushes the air out. The normal space the normal pressure within the pleural space is always a negative pressure, so it's very easy. If we get a little puncture in that, it's going to start sucking things into it. So normally that pleural space is always has a negative pressure in it anyway. The difference between the lung and the pleural space pressures actually help keep the lung from collapsing. So there's a mechanism in there that keeps our lung inflated so it doesn't collapse. If the lung collapsed, it can actually kind of stick together a little bit. But don't think of the lungs as these big, empty bags of air. They're really not. They're those little alveolar sacs is what they are. So you have to think a little bit differently about how the lungs are made too. So there's exhalation. Okay. So how much air can the lungs hold? Normal breathing moves about 500 milliliters of air with each breath. This is what we refer to as the tidal volume, and you'll see it abbreviated as TV. So whenever they're referencing lungs and respiratory and stuff like that, and you see the abbreviation TV, they're not talking about turning on the TV and watching a show or something. They're talking about the tidal volume. So think of tidal volume like one wave on the beach. So one wave on the beach, how big was that one wave? What was the volume of that one wave? What was the size of it? Same thing with breathing. One tidal volume, one breath is about 500 milliliters on average. Okay, it's not the same for everybody. And obviously disease and different things will affect how much air that is. But on average, everything being normal, that's what it is. So other things can affect it. Of course, there's size of the person, the age, sex, physical conditions, and all those kinds of things can affect how much that tidal volume will be. There's also an inspiratory reserve volume, which is the amount of air that can be taken in forcibly over the tidal volume. So our normal breath is about 500 mils, and then we can go ahead and take a whole lot more air in. We don't always take a completely deep breath every time that we breathe. So that inspiratory reserve volume, the amount of reserve that we have, the amount of extra that we have is about 3,100 mils. Of course, remember, it's going to vary by person, and those other factors. There's also an expiratory reserve volume, the air that we can't get out of our lungs, the air that stays in there, which is a good thing that keeps our lungs from collapsing. There's about 1,200 milliliters of air that stays in the lungs all the time. It doesn't have a dramatic effect on us because that 1,200 mils is not in the alveoli. So when we take in more air, it pushes some of that down to the alveoli, helps keep that air a little bit warmer too, and a few other factors by keeping that in there. So that's and then there's that. Of course, there's a expiratory reserve volume. Oh, I'm sorry. The expiratory reserve volume is the amount of air that we can force out after a normal exhalation, so we can kind of still force a little bit of air out. And then the residual volume is the amount that stays in there. Both of those amounts are the same. So expiratory reserve volume and residual volume are both the same. Just remember, expiratory reserve is anytime it's a reserve, we can either take more of it in or there's room for more one way or another, in or out. And the residual volume is how much is going to stay in there no matter what. So we can figure up a lung's vital capacity by taking those normal volumes and adding them together. In men, it's about 4,800. Women, it's about 3,100. Not real often do you see vital capacity being needed to use. And there's also some dead airspace, a zone of air, amount of air that never actually reaches the alveoli. So it's in those main stem, in the bronchi, and all that stuff, the bigger parts before it never gets to the alveoli. And so there's about 150 mils of dead air that's in there. Dead space air, probably not good to call it dead air, but dead space takes up about 150 mils. Okay? And that vital capacity, I'm not going to ask you to do any kind of math kind of thing with that on the test, and I don't even think there's a question on the test about vital capacity. Functional volume, of course, is the air that actually reaches the respiratory zone, that reaches the alveoli. Remember, on average, it's about 500 milliliters, the tidal volume that we take into our lungs. What actually reaches the alveoli is about 350 milliliters of that air actually reaches that. So now, this is going to change with stress and different kinds of things like that, anxiety. That's going to cause us to want to breathe faster, heavier, or larger amounts. It's going to change all that. But these respiratory capacities are, to get a true measurement of that, we measure them with the spirometer. Respiratory therapists do this all the time with patients that are healing and recovering from respiratory things in the hospital. They'll measure them usually once a day or a couple of times a day with the spirometer just to see how they're progressing, if their functional volume is improving. All right? So the movement of non-respiratory gases, non-respiratory air movements. So we do have some movements that happen that really don't serve a breathing purpose or a gas exchange purpose. And of these, we have a cough and a sneeze, crying, laughing, hiccup, yawn. Those don't serve a respiratory purpose. They're not for actually for gas exchange, though gas exchange may occur during those or as a consequence, but that's not what the purpose of those movements are for. All right? So we can listen to lung sounds with the stethoscope, which is pretty handy. Tell us about what's going on in there. And there's a couple of sounds that we can hear with the stethoscope. The first is bronchial sounds, and that's caused by air rushing through the large air passageways such as the trachea and the bronchi. And then we can hear vesicular sounds. Those are the soft air sounds, or the sounds filling the alveoli. Both of those sounds are important, and it's going to vary which one's important depending on what it is that we're looking for, the disease process or something like that. So both of those can be important for us to listen to. This class, we don't talk about those specifically and what those sounds are, how to listen to lung sounds, all those kinds of things. That's going to be part of your training in your class, your paramedic or nursing class, those kinds of things. They'll teach you how to do those lung sounds, and it'll probably be pretty specific to those two professions. So gas exchange is going to occur as a result of diffusion. Remember, it's just simple diffusion. It's those gas pressures, the quantity and gas pressures that's going to cause it to move from one place to another, diffuse. And it's going to move to the area of lower concentration. All right? When we load the oxygen onto the blood, remember that's the external respiration. The alveoli will always have more oxygen than the blood does. Remember, because it's got to pass through all those layers of tissue. So there's always going to be a lower amount of oxygen on the red blood cells than there is in the alveoli, just because it takes so much pressure to push them through. You won't get all that pressure to go through. Oxygen is going to move by diffusion. And then the pulmonary capillaries, those capillaries that are surrounding the alveoli, are going to gain the oxygen that is brought down through. Carbon dioxide is pushed off because of the gas differences, the concentrations. The capillaries are going to give up carbon dioxide, and that carbon dioxide is going to leave through the lungs. This is a measurement that we use. It's becoming more and more commonplace in the hospital and with respiratory therapists, but for paramedics, it's something that we've measured for some time. We can put a little measuring device kind of thing onto either a nasal cannula or some device like that, and measure how much carbon dioxide somebody is exhaling. That measurement of carbon dioxide that they're exhaling is actually a better measurement of how well they're getting oxygen. It tells us whether there's cellular respiration going on, remember? It tells us whether or not they're creating ATP and all that, because the volume of CO2 that's being released gives us an indication of that. Normal, and it's called capnography, but normal CO2 readings, normal capnography readings, is between 35 and 45 of exhaled CO2, 35 and 45% exhaled CO2. So it's another measurement that we use, and it's actually more accurate than pulse oximetry, measuring how much oxygen is getting to the blood. That's not a super accurate reading. It's kind of a ballpark reading because there are other things that can affect that pulse ox reading that can come into play, and it's kind of a little complicated, so we won't get into it, but the carbon dioxide reading in exhaled air is very accurate. We actually use capnography in patients in cardiac arrest to help us determine whether or not we got a return of a pulse. Because if we get a return of a pulse, then we know cellular, we can see that because they'll have a big increase in CO2 exhalation, tells us that cellular respiration is going on. They're creating ATP, and there's some things happening at the cellular level. So we do use those quite a bit in the field, in the pre-hospital setting. So here's that gas exchange again. We just watched a video about it, of the onloading and offloading. I just went ahead and left that little picture in there because it kind of reiterates that. Transport the oxygen in the blood attached to the hemoglobin. There is a small amount of oxygen that is dissolved in the plasma, and that small dissolved amount is actually what the pulse oximetry, the little thing we put on our finger that measures our oxygen level, that's what it reads. The problem is it won't be able to tell us if there's not enough hemoglobin. Say somebody's anemic and they don't have a lot of hemoglobin, they could still be in an oxygen deficit because of that, but because we're only measuring the amount of oxygen in the plasma, we won't know it. We could still read 100% oxygen and not really have enough oxygen on the or have enough hemoglobin to carry enough oxygen for the body to be satisfied, and they could still be hypoxic or cyanotic. So, all right, carbon dioxide. Most of the carbon dioxide is transported in the plasma, opposite of oxygen. Remember, oxygen is transported on the hemoglobin. Most of the, and it's interesting that the reason why most of the oxygen is transported on the hemoglobin is because anytime you have oxygen free in the body, oxygen is actually a free radical. It's not safe to have oxygen just floating around wherever it pleases. So it has to be kind of managed or regulated. The red blood cells do that. They keep it latched onto the hemoglobin. Oxygen is really attracted to the hemoglobin, so it sticks to it. But the pressures, changes in pressures, partial pressures can actually make it leave or have it leave. But so oxygen is carried on the red blood cells, on the hemoglobin of the red blood cells. On the red blood cells as well, there are antioxidants that protect the red blood cell from the oxygen that's on it so it doesn't oxidize the red blood cell. It's kind of crazy. Carbon dioxide, though, is not really, some of it's transported on red blood cells or on hemoglobin of the red blood cells. Most of it's transported in the plasma in the form of bicarbonate. What happens is CO2 is going to bind with water, we're going to bind with H2O, and it's going to create HCO3, which is bicarbonate. Bicarbonate is part of the buffer system that maintains the pH levels. Now, if we have an overabundance of carbon dioxide, it actually will start to be converted into carbonic acid, which is a weak acid capable of releasing hydrogen ions. And that release of hydrogen ions actually lowers the pH and makes somebody become acidic. And it's if it's carbon dioxide that causes that, it's a respiratory problem. It's probably because they're not breathing well. So that's a couple of things that can happen with carbon dioxide. So in order for carbon dioxide to be released out of the blood, it must be released from its bicarbonate form. The way that does that is it's by necessity. As there's less and less CO2 molecules in the blood or on the red blood cells or in the plasma, the bicarbonate is going to release, it's going to separate back out basically into CO2. Sorry, I know I'm bumbling through it, but basically what's going to happen is when the CO2, as the blood returns back to the lungs, the blood that's carrying all the waste products and the CO2 that needs to be gotten rid of, and that CO2 is being transported in the form of carbonic acid. As it gets up towards the lungs and it gets into that tissue around the lungs, that tissue is very, very low in CO2. So the CO2 is going to convert, or the carbonic acid is going to break down, release the CO2 and the water, and the CO2 is actually going to escape to the lungs, and that's how all that is kind of regulated. So carbon dioxide will be stored in bicarbonate, and then it will combine with hydrogen ions to create carbonic acid. Don't get all caught up in the weeds on that. I just wanted you to have an idea of how CO2 is transported. So if asked, CO2 is usually transported in the form of bicarbonate. Okay. So internally, the gases exchange between the blood and the body cells. An opposite reaction occurs is what happens in the lungs. everything switches places going the other way. Here's another little video that we'll watch. It's one of the crash course videos. These are always kind of fun to watch. That talks about the gas exchange process at the tissue and cellular level.
Picture this. You're getting ready to give a big presentation in front of, like, a lot of important people. You're practicing in front of your mirror, and then, just for a second, you forget how to speak. Suddenly you feel that familiar sting of anxiety, like an icy hand on the back of your neck. You look at yourself in that mirror, and you start imagining some of the worst case scenarios. Like, what if you totally lose your train of thought up there? What if you barf? What if everybody gets up and leaves? Now you're really nervous. I'm getting freaked out just talking about it. So you start taking quick, shallow breaths, and you're feeling lightheaded and seeing stars, and now you, my friend, are hyperventilating. When we talk about respiration, we tend to focus on oxygen, and who could blame us? It's easy to forget the equally important role that carbon dioxide plays in maintaining homeostasis. Your internal balance between oxygen and carbon dioxide factors heavily into all sorts of stuff, especially in your blood, where it can affect your blood's pressure, its pH level, even its temperature. And now, at like T-minus 5 minutes to your presentation, all those things are out of whack because you're exhaling more CO2 than you should. You're just about to faint when a friend suddenly hands you a paper bag to breathe into, and you've never been so grateful for a lunch bag in your life because somehow it does the trick. Within seconds, you're back to normal. The drop in CO2 that occurs in your blood when you hyperventilate is called hypocapnia, and it signals a breakdown in one of the most complex and important functions that your respiratory system performs. That is the exchange of gases inside your blood cells, where the stuff your body doesn't want is swapped out for what it desperately needs. This exchange between carbon dioxide and oxygen is regulated by a whole series of biological signals that your blood cells use to communicate with your tissues about what they have, what they want, and what they need to get rid of. It's almost like a code, one that's written into your blood's chemistry, in the folding of its proteins, even in its temperature and acidity. It's what allows you to perform strenuous physical tasks like climbing a mountain. It's also what lets you reboot your whole respiratory system with nothing more than a paper bag. I'll admit it, when we've talked about the chemistry of your blood so far, we've tended to keep things pretty simple. Like hemoglobin contains 4 protein chains, each of which contains an iron atom. Since iron readily binds with oxygen, that's how hemoglobin transports oxygen around your body. Bada bing. But the fact is, hemoglobin's affinity for oxygen isn't always the same. In some places, we want our hemoglobin to have a high affinity for oxygen so it can easily grab it out of the air. And in others, we want it to have a low affinity for oxygen so it can dump those molecules to feed our cells. So how does your hemoglobin know when to collect its precious cargo and when to let it go? Well, a lot of it has to do with a principle of chemistry known as partial pressure. One of the things that fluids always do is move from areas of high pressure to low pressure. And molecules also diffuse from areas of high concentration to areas of low concentration. But when we talk about gases in a mixture, we need to combine the ideas of pressure and concentration. See, air is a mixture of molecules, and when you're studying the respiratory system, you often need to focus on the oxygen, which makes up about 21% of it. But that doesn't actually tell us how many oxygen molecules there are. For that, we need to know the overall air pressure, since more molecules in a certain volume means more pressure. So partial pressure gives us a way of understanding how much oxygen there is based on the pressure that it's creating. Example. The pressure of air at sea level is about 760 millimeters of mercury, but since only about 21% of that air is oxygen, oxygen's part of that pressure, or partial pressure of oxygen, is 21% of 760, or about 160 millimeters of mercury. Now, that's just outside at sea level. When that air mixes with the air deep in your lungs, including a lot of air that you haven't exhaled yet, the partial pressure of oxygen drops to about 104 millimeters of mercury. And in the blood that's entering your lungs after most of its oxygen has been stripped away by your hungry muscles and neurons, the oxygen partial pressure is only about 40 millimeters. This big difference in pressure makes it easy for oxygen molecules to travel from the outside air into your blood plasma because, as a rule, dissolved gases always diffuse down their partial pressure gradients. This is why it's so much harder to breathe at higher altitudes. When you climb a mountain, the concentration of oxygen stays at about 21%, but the pressure gets lower, which means the partial pressure of oxygen also decreases to about 45 millimeters of mercury at the top of Mount Everest. So the partial pressure of oxygen at the top of the highest peak in the world is almost the same as the deoxygenated blood that's entering your lungs. So basically, there is no partial pressure gradient, which makes it really hard to get oxygen into your blood. But let's get back to the red blood cells. Remember that the globin in your hemoglobin is a protein, and when proteins bind to stuff, they tend to change shape, and that shape change can make the protein more or less likely to bind to other stuff. When an empty hemoglobin runs into an oxygen molecule, things are a little awkward. It's like a first date. Bonding isn't so easy. But once they finally bind, hemoglobin suddenly changes shape, which makes it easier for other oxygen molecules to attach, like friends gathering around the lunch table. That affinity for joining in, or cooperativity as it's known, continues until all 4 binding sites are taken and the molecule is fully saturated. Now your hemoglobin is known as oxyhemoglobin, or HBO2, and it is not why the cable network is called that. That's the home box office. Anyway, by the time the blood leaves the lungs, each hemoglobin is fully saturated. The oxygen partial pressure in your plasma is about 100 millimeters, and now it is ready to be delivered to where it is needed most. Active tissues like the brain, heart, and muscles are always hungry for oxygen. They burn through it quickly, lowering the oxygen partial pressure around them to about 40 millimeters. So when the blood arrives on the scene, oxygen moves down the gradient from the plasma to the tissues to feed those hungry cells. That makes the oxygen partial pressure in your plasma drop, so your hemoglobin starts to give up more of its oxygen to the plasma. But partial pressures are only part of what's prodding your hemoglobin to give up the goods. All of that metabolic activity going on in your tissues is also producing other triggers in the form of waste products, specifically heat and CO2. Both of those things activate the release of more oxygen by lowering hemoglobin's affinity for it. Say you're climbing that mountain again and your thighs are feeling the burn. Red blood cells saturated with oxygen are going to the muscle tissue in your quads, where the hemoglobin can dump a bunch of O2 because of the lower partial pressures of oxygen in your muscles. But a hard-working quad will also heat up the surrounding tissues, and that rise in temperature changes the shape of hemoglobin, and it does it in such a way that it lowers its affinity for O2. So when those red blood cells hit that warm, active tissue, they release even more oxygen, like 20% more beyond what partial pressures would trigger. But wait! There's more! Carbon dioxide triggers the release of oxygen too, because it also binds to the hemoglobin, changing its shape again, lowering its affinity for oxygen still more. And as oxygen jumps ship, the hemoglobin can pick up more CO2. Finally, just in case the hemoglobin isn't getting the message at this point, there's one more trigger that your respiratory system has up its sleeve. The spike in CO2 that's released by your active muscle tissues actually makes your blood more acidic. Since your blood is mostly water, when CO2 dissolves in it, it forms carbonic acid, which breaks down into bicarbonate and hydrogen ions. Those ions bind to the hemoglobin, changing its shape yet again, further lowering its affinity for oxygen. So now, at last, your tissues have the oxygen they need, and your red blood cells are stuck with all this CO2 that they need to get rid of. Your red blood cells ride the vein train back to the lungs, where they encounter a new wave of freshly inhaled oxygen. And when that O2 binds to the hemoglobin, which again is hard at first, it eventually changes its shape back to the way it was when we started, which decreases its affinity for CO2. So the hemoglobin drops its carbon dioxide, which moves down its partial pressure gradient into the air of your lungs so you can exhale it, and the whole thing can start all over again. Now, if that isn't enough to make you hyperventilate, I'm not sure what is. But this brings us back to that unfortunate episode you had before your big presentation. This whole complex code of chemical signals that I just described, well, it assumes that what your cells and tissues are telling each other is actually true. But as we all know, sometimes our bodies don't mean what they say. Thanks, buddy. Like when you're freaking out about your presentation, your sympathetic nervous system makes your heart race and your breathing increase to prepare you to fight or flee. The problem is, there's nothing to actually fight or flee from, so your muscles aren't actually doing anything, so they're not using all the extra oxygen you're breathing in. And they also aren't producing the extra CO2 that you're suddenly exhaling all over the place. So when you start to exhale CO2 faster than your cells release it, its concentration in your blood drops. And with less carbonic acid around, your blood's pH starts to rise. And you know what else? Well, low blood pH does things like change the shape of your hemoglobin to deliver oxygen. High pH causes vasoconstriction. Normally this is supposed to divert blood from the parts you're not using during times of stress, like your digestive organs, to the parts that you are using. But when you hyperventilate, this constriction happens everywhere, which means less blood is delivered to your brain, which makes you lightheaded. Luckily, that trick with the breathing into the paper bag, it really does work. It works because it lets you breathe back in all of the CO2 you just breathed out. So the partial pressure of carbon dioxide dioxide in the bag is higher, which forces that CO2 into your blood, which lowers its pH, and you get back to homeostasis. And of course, homeostasis is the key to life. And also to a successful presentation. If you were able to remain calm today, you learned how your blood cells exchange oxygen and CO2 to maintain homeostasis. We talked about
Hopefully that was helpful, given what we've already talked about. I think he covered a lot of the same things that I talked about, but he did it in a little bit of a different way, a little bit funner way. I wish I had his energy. If I could talk as fast as him, maybe I could get through a lecture in about half the time, but hopefully that helped out. Feel free to watch that video as many times as you want. Of course, our respiratory system would be nothing if there wasn't something controlling it. We have the ability to control it on our own, but there is a regulatory center that controls controls breathing and those kinds of things, absent our conscious control of them, which is a good thing. The two centers that control breathing regulation are the medulla and the pons. Those are both good test questions, although I can't remember if I put a test question on there about the medulla and the pons. I know I looked at one, but I don't think I put it on there. But be familiar with the medulla and the pons. Remember, they're both located in the brainstem. And because they're both located in the brainstem, a lot of times when we have a brain injury that causes the brain to swell and the pressure pushes the brain starts to push the brain through the base of the skull, it puts pressure on the brainstem. One of the first indications of a severe brain injury that we see is erratic breathing patterns. And that is caused by the pressure on the medulla and the pons that affects the breathing pattern of the person with the head injury. Normal respiratory rate we call eupnea is 12 to 15 respirations per minute is normal. Now, you'll look at one book that'll say 12 to 15, and you'll look at another book that says 12 to 20, and I don't know why there's so much a discrepancy, and that's going to vary depending on the age of the person that you're talking about. So infants and children, their respiratory rates are faster because they have a much faster metabolic rate because their little bodies are growing and creating new cells and using up a lot of ATP and all that stuff. So they have a faster respiratory rate. Hyperypnea is an increased respiratory rate due to over-oxygen or due to extra oxygen needs. There are some physical factors that influence our respiratory rate and depth, and they are increased body temperature. One of the ways that our bodies will try to combat a fever is to breathe faster or to reduce body temperature, not necessarily a fever, but if we're just hot and sweaty. Exercise is going to affect the rate, talking, coughing. My respiratory rate's probably dramatically increased while I'm lecturing. We do have conscious control over our respiratory rate, and there, of course, are some emotional factors that can affect that as well. Chemical factors such as CO2 levels. The body's need to rid itself of CO2 is the most important stimulus for breathing. So we have that. It's the CO2 thermostat in our body that triggers us to breathe or faster or slower. It's the main one that does it. It's not oxygen. It's a little surprising that it's not, but it's CO2. The increased levels of carbon dioxide affect the blood pH, and that's part of what triggers us to breathe faster. Or if we have a lower pH or a higher pH, it'll trigger us to breathe slower. Changes in oxygen are detected by some chemoreceptors in the body, and that information is sent to the medulla. And so while oxygen levels do have some effect on breathing, it's not very much. It's a very marginal effect. It's mainly CO2 that has that effect. Hyperventilation causes a rise of CO2 levels in the blood. From acidosis, it results in faster, deeper breathing that we call hyperventilation. What happens is we blow off more CO2 to get the blood pH back to normal. And it may result in apnea or dizziness that can cause some alkalosis if the hyperventilation is more anxiety induced and not for a good reason. All right, hypoventilation can happen too when the blood becomes too alkalinic, meaning it's let off too much CO2, and then we might see some very slow or shallow breathing. This allows a buildup of CO2. Now, we might see hypoventilation or agonal respirations, these really infrequent gasps of air. We'll see that with patients in cardiac arrest. That is not really the true sense of hypoventilation. It is more the fact that the heart has stopped beating and the brain is dying and the respiratory centers are shutting down. It's just kind of agonally throwing a breath out there because everything has stopped. COPD is a group of respiratory medical conditions that are often referred to in healthcare that are usually a big deal. It is accounts for a large percentage of the patients that we usually have to deal with, especially in the winter months and early spring months. Typically, it's chronic bronchitis and emphysema, but sometimes they'll throw asthma within that, and it's an obstructive disorder or an obstructive condition of the alveolar area of the lungs, where there's some obstruction of air getting to there, either because thickening of mucus or thickening of the walls or poorly functioning alveoli. So it's one of the major causes of death and disability in the United States, oftentimes caused by smoking, but can be caused by environmental factors such as working in a factory, exposure to chemicals, and those types of things. Features include patients are almost have a history of smoking, labored breathing that eventually starts to become worse, coughing and frequent pulmonary infections are common. My physician told me that as we age, our lungs become less elastic, so respiratory conditions start to become more prominent. So why is it that most of the time these COPD disorders, such as emphysema and all those, only start to show up when we get older? Well, first of all, it's because it takes that long from all the smoking for that to happen. Second of all, as we age, our lungs become less elastic, so those things start to become more prominent and they get progressively worse. There is good news that if you quit smoking early enough, you can reverse most of the damage within about 5 years, and then within about 10 and 15 years, it's almost like you've never smoked before, at least in theory, that for the most part, anyway. So quit smoking; it'll help. The most victims are hypoxic and they hold on to carbon dioxide. This is an interesting feature of COPD, is their retention of that carbon dioxide actually resets their carbon dioxide thermostat, meaning they're used to having abnormally high levels of CO2. When we give them a bunch of oxygen and we make them blow off a bunch of CO2, it may actually cause them to stop breathing altogether, and it won't kick back in like it normally would in the rest of us. So they have they rely heavily on what's called the hypoxic drive, that carbon dioxide drive. So we have to be cautious in the administration of high amounts of oxygen for long terms in COPD patients. But I'm going to tell you, if a patient needs oxygen, we give them oxygen. But we might need to think about the percentage or the concentration of oxygen that we give them over a long period of time. In the short term, large amount of oxygen really isn't going to hurt just about anybody. But over the course of a day, a week, that kind of thing, it can start to be very problematic, and especially for COPD patients, they may stop breathing altogether. Chronic bronchitis is there's a mucus in the respiratory passages that becomes severely inflamed. So we have inflammation and mucus in that respiratory passages that starts to become inflamed, and it impairs the ability for air to reach those alveolar areas. Sometimes we call these guys blue bloaters because it's a chronic condition, and they become cyanotic. They start to get that blue look because of that. The alveoli are permanently enlarged as adjacent chambers break through and are destroyed. The continued inflammation causes fibrosis of the lungs, which is scarring of the lungs and the replacement of that. And patients use a large amount of energy just to exhale. Exhalation starts to become a more active process. They're actually having to physically force the air out of their lungs. That's overinflation of lungs usually will lead to a permanent expanded or barrel chest look. And cyanosis appears late in the disease. And this is emphysema. And cyanosis usually appears kind of late. These guys are usually, we refer to them as pink puffers because they're having trouble breathing, but we don't see the cyanosis like we do with the chronic bronchitis. Chronic bronchitis is going to have the cyanosis where emphysema won't. It kind of helps you separate the two. Treatment for them is really not altogether that different. Basically do the same things, at least in an emergency setting. Long-term, the treatments are a little bit different. At least the long-term medication that a physician's going to prescribe to them might be a little bit different. But realize that with any of these respiratory diseases like this, it's a little bit of a moving target trying to find the right combination for some of these patients, and that's going to change as their disease progresses. Both of these diseases are progressive, and it is likely to be what will be a major contributing factor in what they die from. So whether it's the exact cause or it caused something else to cause their death, it's going to be a major contributor. Lung cancer, very aggressive and metastasizes rapidly. It's one of the most aggressive cancers out there. About 1/3 of all U.S. cancer deaths are lung cancer deaths. Much increased incidence associated with smoking. And then there's 3 common types of lung cancer down here, and which we don't really need to get into what those are specifically, but just there's 3 different types. There are some things that we need to consider in the developmental phases of the respiratory system. Premature babies have, usually the lungs are one of the last things to develop in babies. So if they're preemies, their lungs don't stay real well inflated because of the lack of surfactant in the alveoli. It hasn't been created yet. That surfactant comes in late in pregnancy. Like I said, the lungs are kind of the last things to develop. Infant respiratory distress syndrome, it's where the surfactant that the baby's producing is inadequate, and that's going to create a lot of problems. There's a lot of birth defects that affect the respiratory system, even physically, structurally of it or the functioning of it. Cleft palate, cystic fibrosis is an oversecretion of the thick mucus that clogs the respiratory system. In the process of that, it also creates the fibronic of that. There's the scarring inside of the lungs. Cystic fibrosis is usually something that happens with younger children. The only fix for that is a lung transplant. So it can be pretty sad for those little guys and the parents and families having to deal with that. So respiratory rates change throughout life. Remember I said normal for adults is 12 to 15 on that slide back there. It's funny, this one says 12 to 18. Like I said, you're going to see in different books they're going to call it 12 to 18, 12 to 20. I've almost always seen them consistent with the 12, but 15, 18, and 20 is pretty common for them to move on up through there. So, but you can see newborns, infants, 5-year-olds, they have different respiratory rates. Once again, there's a lot of metabolic activities going on in there, so a lot of release of CO2 and that kind of stuff, a lot of oxygen demand. So that's why they breathe so much faster, in part. There's some other factors in there too. SIDS, or sudden infant death syndrome, basically a healthy infant, otherwise healthy infant, just stops breathing and dies during their sleep. Some of the causes are thought to be a problem in the respiratory control center. 1/3 of the cases appear to be due to a heart rhythm. And recent research shows some genetic components, though they still don't really have anything nailed down on this. I've been in healthcare for 25, going on 30 years, and it's still really unknown. It's still very much a mystery, which is very heartbreaking to these families who've had to endure losing a child to this, because typically they're young families and they're young couples, and they're trying to do the right things, and their child dies unexpectedly, and they automatically blame themselves when it probably isn't have anything to do with their parenting abilities. It just happens, unfortunately. Of course, asthma is chronically inflamed hypersensitive bronchial passages that respond to irritants and causes shortness of breath, coughing, wheezing, all that kind of stuff. I remember as a kid, I grew up with asthma. I still have a few issues with it today. But I remember as a kid, I could be with my mom in the store, and we'd walk up to the aisle to check out or whatever, and we'd get behind some little old lady that had their Chanel No. 5 or some perfume that they've just almost bathed in, and I would get a whiff of that, and it would just cause my lungs to just lock up, and I just couldn't breathe. I'd just be, trying to breathe, and my mom's looking at me like, "What's wrong with you, boy?" And and I just couldn't breathe. So I struggled with that quite a bit, and different allergens and things like that, dogs, cats, you name it. I was pretty much allergic to it as a kid. Affected my breathing. I was according to my parents, I was pretty bad. That I was kind of fortunate to have survived it and come out of it as well as I have. As an aging adult, I'm starting to notice a few more asthma-related issues that I haven't had for 40 years. And now they're starting to come back, and my physician tells me, well, that's because there's a little bit of loss of elasticity within my lungs. So something that we're watching and see if there's anything that will need to be done in the future about it. Probably not. But also, most respiratory problems are the result of external factors in the youth and the middle-aged people, such as physically blocked respiratory passages from substances or infections and that kind of stuff. The one thing that I do want to point out is in infants and children, when it comes to heart problems and those kinds of things, most of their problems are respiratory related. So whenever you're caring for an extremely ill or infant or child that has maybe even went into cardiac arrest, the first thing that I would be wanting to make sure was secure was an airway. I'd make sure we had a really good airway and that we were ventilating for them, and we were looking at our capnography and oxygen readings and those kinds of things, because they're very important to these little guys. And they also, when they do have respiratory problems, the littler they are, the less resilient that they are. They don't usually go through the same stages as an adult when they're having respiratory problems. They will go from difficulty breathing and not looking really well to not breathing at all, almost in the blink of an eye. So when we're dealing with the little ones and breathing and respiratory issues, we typically teach our paramedic students to be pretty aggressive about those, pretty aggressive in our approach to those, and not take anything for granted with the little ones. All right. As we get older, the lungs become less elastic. The capacity of the air that they can carry becomes less. Oxygen levels decrease. Stimulating effects of the carbon dioxide decreases, so carbon dioxide doesn't have the same effect. Elderly are often hypoxic and exhibit sleep apnea a lot of times now, where they're selling all these, breathing devices and all that stuff, CPAPs and BiPAPs and all that stuff that people sleep on. So that's been helpful. It's actually helped with a lot of other medical issues too by recognizing sleep apnea. A lot more risk of respiratory infection too with our elderly population. Very high incidence of pneumonia and those types of things. So, all right, so that's chapter 13. I'll see you guys at chapter 14.